Hello everyone, I'm Dr. Vamsi Krishna, consultant neonatologist and pediatrician at KIMS Cuddles, Kondapur. Nowadays, we are able to save so many small babies, and especially the babies who are born less than 28 weeks, less than 1 kg babies. These are the small extreme preterms and the elegant babies. So today, we are able to salvage so many of these babies also. Now we'll discuss how we are managing these extreme preterm elegant babies based upon a case, and we'll see what are the evidence-based practices that we are doing and we need to adopt. So the objective of my presentation is first we understand what is the clinical outline of the case. The next thing is we see how we are managing our delivery room, then how we manage in our NICU, and how we are discharging and how we are following up the babies. So to begin with, we have a 23 years old primary mother. Around 25 weeks of gestation is. Mother is antenatally registered with us, and her first and second trimester went uneventful, and the antenatal scans were normal. She was presented to us with a history of premature onset of labor pains with leaking PV of around 18 to 20 hours. She doesn't have any other medical or obstetric complications like PH, gestation diabetes mellitus, and hypothyroidism. And there was no any history of the bleeding PV or decrease in the fetal movements. In view of this PPROM, we have admitted the mother. We have given 2 doses of the betamethasone. We have started for the magnesium sulfate for the neuroprotection, and IV antibiotics were given to the mother. So these are the interventions that we have given antenatally. Why we have given all these antenatal interventions? So how will these interventions affect the outcome of the baby? Every medicine that we are giving to the mother or the baby will have certain effects on the baby. Interventions, especially the antenatal steroids, they need to promote the maturity of the lungs. They need to promote the production of the surfactant. They lead to the maturation of the cerebral blood vessels. They need to maturation of the gastrointestinal tract. So in this way, we have a strong evidence. The recent evidence in Cochrane 2020, where we found that the chance of the perinatal death is decreased by 15%. There's a 22% decrease in neonatal death, 29% decrease in the respiratory distress syndrome, and 42% decrease in the IVH. And there is nearly 49% decrease in the chance of the developmental delay. So the antenatal steroid aided betamethasone 12 mg IM 24 hourly and dexamethasone 6 mg IM 12 hourly 4 doses, followed by 24 hours of gap, and then we have delivered the baby within the first 7 to 14 days after the last dose, and after 24 hours after the second dose. Then the outcomes are much better. The next important intervention that we are given is the magnesium sulfate. So the magnesium sulfate is an NMDA receptor antagonistic. It decreases the excitatory glutamate response. It has an antioxidant, anti-inflammatory. It stabilizes the cerebral blood flow. In this way, it reduces the risk of the cerebral palsy and the combined death in the cerebral palsy and severe grades of the intraventricular hemorrhage. So all less than 32 weeks and majority of cases less than 34 weeks also, we are giving the magnesium sulfate as a 4 grams IV loading dose followed by 1 to 2 gram per kg per hour for the 24 hours or till the baby get delivered, which was the earliest, is showing much better neurodevelopmental outcomes. This is the antibiotics. So based upon the Oracle's one study, so any mother who had presented with the premature rupture of membranes and preterm onset of labor pains, erythromycin has shown to decrease the abnormal cerebral ultrasound scans, decrease the chance of the culture positive sepsis, and decrease the chronic lung disease in the babies. So in this way, these 3 interventions play significant impact on the long-term effect of the baby. So after this intervention, we are able to successfully deliver the baby vaginally. Baby has cried immediately after birth. We have done the delayed cord clamping for around 30 seconds. The birth weight of the baby is around 730 grams. We have received the baby in the plastic bag covering the head and the body. We kept the baby under the radiant warmer of the pre-warm layer. Baby had a respiratory distress with a Silverman-Anderson score of 5/10. So delayed cord clamping is a norm nowadays in majority of the areas. So multiple studies have been done regarding the importance of delayed clamping in both the term and the preterm babies. So what is delayed cord clamping? So the early cord clamping is the clamping that usually carried out in the first 60 seconds after birth. To be more specific, usually within the 15 to 30 seconds. And the delayed cord clamping is the clamping carried out more than 1 minute after the birth or when the cord pulsation has ceased. So when you can see this picture, we can see that as we delay the cord clamping from the immediate to maybe around 30 to 60 seconds, we can increase the blood volume from around 70 to 80 to even 85 ml per kg blood. So on average, by delaying from 30 to 60 seconds, we can increase the blood volume of the baby by 15 to 20 ml per kg. The evidence is very strong. You can see that in the preterm babies or low birth weight babies, the delayed cord clamping decrease the chance of intraventricular hemorrhages, decrease the necrotizing enterocolitis, decrease the late onset sepsis, and there is a decrease in need for the blood transfusion, surfactant, and the mechanical ventilation. These babies tend to have a more amount of hematocrit, hemoglobin. They have a more stable blood pressures. The cerebral blood oxygenation and the red blood cell flow is also good. Not only in the immediate effect, the long-term effects, there is increase in hemoglobin around 10 weeks of age. They have a better neurodevelopmental outcomes. In the case of full terms, there is an increased chance of hematocrit and hemoglobin, and the long term, the hemoglobin status and the iron status at the 6 months of age are high. So in this way, the delayed cord clamping should be done in all the babies who have been tried at birth. Even nowadays, the much research is happening on the babies who are not even crying. The interplacental resuscitation is the thing that has been more popular nowadays. So many studies are being conducted, and in the future, we may get much more important guidelines based upon the interplacental resuscitation. So these are all the important delivery room interventions that we need to follow in order to have a positive outcome. Temperature. The temperature is one of the vital parameters in our newborn. Maintaining the temperature since birth is paramount important. In order to maintain the temperature, we need to keep our delivery room temperature at least by 23 to 25 degrees centigrade. We need to cover the baby with a plastic bag or wrap and hat. We don't dry the baby because the skin is so immature that there will be more amount of transabdominal water loss. As soon as you are being drying, there will be reaccumulation of the water over the skin. By keeping the baby in the plastic bag or wrap, this superficial, the water, the amniotic fluid, and the plastic wrap create an environment over the baby and it acts as the humidity over the baby. We need to always have a radiant warmer in place with preheated and put heater output around 100%, and we need to heat the linen so that the baby will not lose the temperature by the conductive mechanism. We have discussed that delayed cord clamping is a norm. In these less than 28 weeks of the babies, the strict guidelines have been that less than 28 weeks, we should not do the intact cord milking because the rapid surge of the blood going into the baby by doing the intact cord milking will lead to the more amount of intraventricular hemorrhages. Previously, for any baby who have a respiratory distress, much prior, they used to intubate the babies. But we have a robust evidence from many studies. We are clearly in all the centers, we are using the delivery room CPAP instead of the intubating these babies. So the delivery room CPAP should be provided to all the babies. Along with this thing, the heated and the humidified respiratory support should be provided immediately after the delivery in the delivery room CPAP in order to decrease the temperature loss from the baby. And the blender is a paramount importance for managing all the babies. So we need to put the FiO2 at 20 to 30% because providing very high FiO2 to begin with may increase the chance of survival, but the chance of babies getting the spontaneous respiratory effort is much delayed by using the higher FiO2, and the baby's chance of VPDs, retinopathy prematurity, are higher when we're not using the blender and using the 100% effort. The baby's cardiovascular support should be provided immediately as soon as the baby is born and put on the CPAP and they get temperature stabilized. We need to put the umbilical lines in order to maintain the normal perfusion in the blood pressures. We follow the strict blood pressure guideline charts and we follow the blood pressure based upon the gestational baby's blood pressure values. So after the baby has been stabilized in the DR, we have shifted the baby to NICU on the CPAP. We tend to nurse all less than 30 weeks and less than 1 kg babies in the incubator with around 80 to 85% humidity, and we have started the IV fluids. At the time of NICU admission, baby was requiring the CPAP of 6 centimeters of water with the FiO2 45% to maintain a saturation of 91 to 95%. The Silverman-Anderson score of the baby is 3 by 10. So what is the next step? So now we'll divide the management plan in the NICU in the following heading: respiratory support management, cardiovascular management, neuroprotection, infection prevention treatment, fluids and feeding management, jaundice and the metabolic disorders management. Go each topic in detail. So for the respiratory support, we continue the baby on CPAP. Chest X-ray. The chest X-ray suggests of the prominent air bronchogram with the obliteration of cardiac silhouette. So normally we do the chest X-ray, we'll grade the RDS. Previously, the typical pattern of low lung volume with the whiteout lung may not be seen in all the babies because we are providing the delivery room CPAP, which alter the X-ray parameters. So routinely, For a grade 1 RDS, we see a symmetrical reticulogranular pattern. RDS is a symmetrical disease, so bilaterally we can see this fine dot kind of things. These are the reticulogranular pattern. These are not actually the collapsed alveoli. These are the alveolar ducts and sacs. So these babies doesn't have an alveoli. The grade 2, when this RDS is much more severe, the surrounding, the other connecting areas will also get collapsed, and there's more dense collapse that happens. So your prominent air bronchograms will be there. And if further progress in this grade 3 RDS, along with the grade 1 and grade 2, we can have the obliteration of the cardiac ciliary under the diaphragm will be there. When there's more dense opacity, the completely white out lung will be there. So here we have a reticulogranular pattern, the decreased transparency with the prominent air bronchogram, and we're not able to see what is the cardiac portal properly. This is a grade 3 RDS. Any center, getting an X-ray and the film may take some time. And sometimes with the X-ray, because of the CPAP, we are not able to get a clear picture that we used to get previously. So here the importance of the lung ultrasound is there. So normally we are doing for all the babies who are respiratory distress, we are doing the lung ultrasound as soon as the baby gets stabilized in the TR and transport to the NICU. We follow all the infection prevention practices while doing this. So we'll divide the lung into the upper anterior, lower anterior, and the lateral of each lung. So we have 6 areas. And these are the lung ultrasound patterns that we have seen. So we have had a session on the lung ultrasound previously. So one can go to the lung ultrasound session done by me only. So you can know what are the different kind of the patterns. Routinely, this is a 0 score will give for a pattern where this is normal, and will give a score of 2 where we can score of 1 where we can see a B line presence of 3 or more B lines. And we can give a score of 2 when there is a severe B pattern where there is a crowd and the coalescent B lines with subpleural consolidations. In the case of a score 3, we have an extensive consolidations and we have a dense opaque kind of things. The score, the minimum score is 0, that means a normal lung, and the score maximum 18, that could be white out lung. And we label the RDS as a mild based upon the 1 to 6, 7 to 12, and more than severe, and the severe is more than 12. So we do the lung ultrasonography, we score, we found the every time we found the score of more than 8, we are giving the lung. Based upon the lung ultrasound in these 6 areas, we are giving surfactant. So the LISA technique is the one that we are following here. So where we give the surfactant when the lung ultrasound score is more than 8, because the LISA compared to the routine has shown to decrease the chance of the risk, compared to the insure has shown to decrease the chance of the death, BPD, and the severe intraventricular hemorrhages. The chance of pneumothorax is similar between the LISA and the insure. So why we are giving surfactant? So we need to give the surfactant because these babies doesn't have surfactant. They might have given antenatal steroid. That is the reason the baby might be able to maintain the baby on CPAP, but still they might be deficient in surfactant. So we are giving the surfactant whenever the baby is requiring more than 30% of FiO2 on a CPAP of 6 centimeters of water, based upon the European Consensus guidelines in the 2020 update. We're not giving any prophylactic surfactant. Previously, in much earlier, people used to give the prophylactic surfactant, but the studies have found it's not going to improve any outcomes, and there is more chance of the intubating the baby and giving the baby more chance of the air leaks. So nowadays, we are not providing any prophylactic surfactant. We provide the baby in the delivery room CPAP. We try to maintain the baby on CPAP. We give the early surfactant within first 2 hours after birth when the requirement of more than 30% of FiO2 and 6 ml of CPAP. All these small babies, it's better always to give the Protectant alpha for 200 mg per kg of phospholipids as compared to the Baractan, because these are very small ET tubes, maybe around 2.5 ET tubes. So providing 2.5 ml per kg through the 2.5 ET tube is not that problematic compared to this 4 or 5 ml per kg giving through these small ET tubes. And also they found that the mortality and the bronchoballoon dysplasia in PDA are much less compared to the Baractan. However, the problem is in the Protectant alpha, we are giving 200 mg per kg phospholipid, and the Baractan, we are giving only 100 mg per kg phospholipid. So there is a controversy which one is better, but compared to the volume, definitely the Protectant alpha is much less than the Baractan. And we have already seen that we are giving LISA, because by giving the LISA, there is a chance for the death, BPD, and the severe intraventricular hemorrhage is less compared to the insure. So this is a LISA catheter that we are using. So rather than intubating that baby with the ET tube, we insert the LISA catheter into the trachea, just bypassing the vocal cords, and then we are giving the surfactant drip by drip. In this way, the baby will be continuously connected to the CPAP, is attached to the baby in post-tubal ventilation. We are avoiding the post-tube pressure breath, Even 4 to 5 breaths also can lead to this inflammation in the lung and can lead to the bronchopulmonary dysplasia. That's why we are using Lisa catheter and we are using the Lisa mist. So this baby, because of adequate antenatal steroid, we are given the timely surfactant therapy. So the baby effort requirement got decreased to the 21% over the next 6 hours. And as a baby is a extreme premature baby, we are continuing the baby CPAP till 13 days of life in order to prevent the apneas and the de-recruitment. After 13 days, then we have transferred the baby to the HHFNC, which we are given for day 28 of life. Then we weaned off the support and made off support by day 28 of life, after which the baby remained off respiratory support. Around 24 hours of life, this baby has developed shock. So all the preterm babies are more prone for the shock because of the 3 important reasons. One, because of the prematurity related myocardial dysfunction. Second, because of the HSPDA. And third, last but not least, the sepsis should always be considered in the case of small premature babies when there is a risk factor for sepsis. So this baby had a shock in the form of tachycardia, delayed CRT, bounding peripheral pulses with wide pulse pressure. So we consider the important possibilities of HSPDA, myocardial dysfunction affected prematurity versus sepsis was considered. The ABG was consisted of partially common metabolic acidosis with the acidemia, with the hypocarbia, the normoxemia, with low bicarbonate and elevated lactate. So this baby is having cardiovascular compromise. We have done a 2D echo in order to differentiate between the HSPDA with the myocardial dysfunction. So I'm just showing the one of the parameters. I'm not going to the depth into all the PDA parameters. So this we can find a large PDA with maybe bidirectional shunt, but predominantly left to right shunt. So the echo parameters in this baby, we do the fractional shortening where we see this left ventricular contractility in the plaques view. The normal is around 25 to 45%. We found this baby around 29%, which is normal value. We have seen the IVC collapsibility. IVC collapsibility we usually see in these babies in order to depict any fluid response status for the shock. Anything less than 50% is suggestive of the normal intravascular volume. So the inferior vena cava collapsibility is 38%, so we interpret as normal. The 2.1 PDA is there, which is of moderate size. The LLO ratio is 1.8:1, which is a moderate size, and the E to A ratio is 1.4. The left pulmonary industrial velocity is 44 centimeters per second. So these are all indicate any 2 parameters of these parameters of the PDA will suggest of a hemodynamic significant PDA. So we have taken this as HSPDA. I'm not going into the depth of all the HSPDA findings and echo findings. So based on these are the parameters that we are using in our hospital. So we label this baby as HSPDA. So as this baby had HSPDA, the baby has received IV paracetamol on 15 mg per kg per dose. Sorry, it's not day, dose, every 6 hourly. We had done the fluid restriction. For the shock, we have given the dopamine of around 10 micron per kg per minute. Slowly, the shock parameters improved, and we are able to close the PDA by day 3 of PCM. And then the dopamine was tapered and stopped over the 48 hours, after which the baby remained hemodynamically stable. So why we are using the paracetamol? Why we are using the dopamine? Why paracetamol? Previously, the drug of the choice was indomethacin. So we used to give the indomethacin during the maybe around 4 to 5 years before, where we used to give the IV indomethacin. Sometimes we are giving the prophylactic indomethacin also at that point of time. But slowly the paradigm has changed. Then we have come to early targeted ultrasound, early targeted echo, and we are giving the ibuprofen, oral ibuprofen, which was equally efficacious with indomethacin. Then we are used to see so many complications with the ibuprofen in the form of feed intolerance, GI bleeds, oliguria. So then, as the studies have been done more on the paracetamol, then we started in the paracetamol because we found the paracetamol is equally efficacious to ibuprofen in majority of the studies. But the problem is all the studies have been done for the closure of the paracetamol, closed of the PDA. So we don't know the long-term effect of the paracetamol. There are certain studies suggesting that the paracetamol administration in these babies can lead to the increased incidence of autism. And in the small elegant babies, the paracetamol cannot be provided in a paracetamol itself cannot act completely because the proximity in these babies is not well established. So we don't know whether in these small babies, less than 26 weeks of babies, whether the paracetamol is definitely helping or the duct is getting closed by itself. And there's so much of debate nowadays that these all babies require the pharmacological therapy. Based upon the Oscar trial also, they doesn't have any long-term benefits by giving these drugs, and we are actually exposing the babies to these drugs which we don't have a long-term. outcomes. But as the evidence is not still clear whether to use or not, so we use in the case-to-case basis where we found a significant metabolic acidosis, where we found the babies having a hypertension, and when the babies have increased their F2 requirement, then only we are giving the treatment. Otherwise, we are trying to conservatively manage the baby with fluid restriction, with providing good amount of respiratory support and monitoring for the shock and the metabolic acidosis. And this baby has hypotension and worsening metabolic acidosis. That is the reason we are giving the paracetamol. But the debate is still going on. In the future, we will get more evidences whether to use the drug therapy for closing the PDA or we have to wait and see. Dopamine, we have started 10 micron per kg per minute because at this dose, it acts on the beta 1 receptors, which increase the positive inotropic and chronotropic. So their cardiac output will increase. At the same time, the alpha action will lead to the vasoconstriction of pulmonary vessels. So the chance of the left to right shunt at the PDA will decrease and simultaneously improving the cardiac output. So the baby's forward flow will be good and there's no diversion of the blood. There's no steal. And there's no pulmonary flooding. So that's why we choose the dopamine to be given in these babies. Next, one of the most important is neuroprotection in these babies. So these small babies have very tiny, fragile vessels, and they're subjected to so many fluctuations in the cerebral blood flow because of ventilation, because of pressures, because of lack of cluster caring, so much of stimulus around this, maybe bolus, giving the IV rapid boluses. So all the things can lead to the more amount of the intraventricular in these babies. So what we have seen is if you are able to prevent the intraventricular hemorrhage in the first 3 days of life, the chance of having the intraventricular hemorrhage is much less in subsequently. So the first 72 hours is paramount important in order to prevent the intraventricular hemorrhage. We need to follow strict intraventricular hemorrhage care bundle. So we usually achieve this by positioning the baby in the incubator by tilting to 10 to 20 degrees so that the venous flow from the brain to the heart will be good. We follow the clustered care and individual care rather than the family-based care. We monitor the stress scores, pain scores, and we adequately support the babies by reducing stress and pain. We avoid the constant light exposure by covering the incubator with a transparent cloth, opaque cloth. We avoid noises by setting the alarm tones as quietly as possible, and we always address the alarms quickly. We don't tap or place any objects on the incubator, and we always have our conversations and the rounds with the consultants away from the incubator. We strictly following slowly drawing the blood samples from all the lines, and we try to avoid the rapid boluses. We avoid the hyperosmolar agents like sodium bicarbonate routinely in all the babies. We always try to non-invasive ventilation. If required, we always go for the PTV with volume guarantee mode of ventilation, as we've seen this prevents the hypo and hypercarbia, so the chance of the bleed is less. And we are not routinely following the FFPs, ethamsulate, phenobarbital, vitamin E supplements because the evidence is still lack. We do the neurosonogram on day 1 by ourselves only, and we'll screen on the day 1, day 2, day 3. If there is any bleeds, some kind of things, we'll always confirm with our radiologist. So we found this baby as a grade 1 IVH, and after day 3 and day 7, this got improved, and there is no dilatation subsequently. We screen our radiologist screen on day 14, and there was no any change of the PVL, and all the developmental support to care we have given for the baby in order to have a positive development. So this is 5 important components of development support care. We need to provide a protected sleep. We need to address the pain and manage the stress. The families we are allowing to care of the baby so that they touch, their stress levels, everything will be good if they've been allowed for the care of the baby from the time when the baby's been stabilized so that the babies can have early discharge and they have better attachment to the family. Provide a healing environment but avoiding the sounds, light and all the things. And all the developmental support to activities of the daily living will be followed strictly. So in order to have a good developmental support to care. These babies have more skin permeable, more chance of the breakage of the skin, more chance for the infection because of the multiple lines are there. So many of manipulations will be done with the lines because of some many drugs and maybe on mechanical ventilation more prone to the VAP. So infection prevention, if you prevent these babies' infection, support them properly, the majority of the things the baby will be adjusted by baby itself, and there is no need for any higher kind of the equipment for salvaging these babies. So we need to have a strict hand hygiene and we need to follow the 5 moments of the hand hygiene. The VAP and the CLAPSI bundles should be followed strictly. We need to prepare all the medications, fluids, and the total parenteral nutrition with the help of the laminar airflow. The skincare is a proper important. We need to avoid removing the plasters, adhesive tapes, so in a very rough and the quick way in order to prevent the damage on the skin. The enteral feeding is a paramount important in these babies, and as early as possible, as soon as we get a chance, we always try to feed the babies with the mother's own milk. We follow the probiotics in order to decrease the late onset sepsis and decrease the chance of necrosing enterocolitis. The strict antibiotic stewardship is needed to prevent the emergence of the drug resistance and the development of necrotizing enterocolitis. So these babies in view of a PPR may started on IV antibiotics, peptides, and amicas per the unit policy. The initial sepsis screen is normal, the blood culture is instituted normal, so we stop the antibiotics after the 72 hours. On 7 days of life, baby had an abdominal distension with aspirates, baby had apnea and the tachycardia. So the possibility of the feed intolerance, the necrotizing enterocolitis, dyselectrolytemia, or the sepsis in the form of bacterial fungal sepsis was suspected in view of all the symptoms of abdominal distension, apnea, and feed intolerance. We have done a blood test. The sepsis screen suggests of leukopenia, neutropenia with an elevated CRP. These babies, the problem in these babies, they may not bond a high CRP, but we need to be vigilant because of the leukopenia and neutropenia may be one of the earliest markers that we can find in the blood test. The baby also had a thrombocytopenia. We done excessive dilated bowel loops. The electrolytes were normal. We have removed the umbilical venous line as the baby has more than 5 days. We usually remove by 5 to 6 days. We have inserted PICC line. We started antibiotics of meropenem in view of sepsis and also the amphotericin B in view of thrombocytopenia. We kept the baby NPO for 48 hours. Slowly, as abdominal symptoms improved, after 4 days, the CPC was normal. The blood culture steroids, the antibiotics and antifungal were stopped after 7 days. This is much more important. Is meticulous adjustment of the fluids is needed. Routinely, we follow in these small babies around 80 ml per kg, 100 ml per kg, 120 ml per kg, and day 1, day 2, day 3. And then we need to adjust the fluid by 10 ml per kg per day till 200 ml per kg per day. But this is an arbitrary thing. We will increase or decrease the fluid volume based upon the weight of the baby, urine output of the baby, electrolytes of the baby. Sometimes we do the urine specific gravity to see whether the baby is having concentrated urine or the diluted. As a part of the early aggressive nutrition, we start all these small babies less than 1 kg with the total parenteral nutrition on day 1 itself. We start with a GR of 6 mg per kg per minute and increase by 1 to 2 mg per kg per minute with a maximum of 10 to 12. We try to maintain our sugars levels in between the 100 to 150. We'll tolerate till 200. If anything more than 200, we'll try to decrease the GR. We don't give insulin to increase the high amount of GR because it has found that giving the insulin to maintain the high GR will lead to more amount of lactic acidosis, more amount of hypoglycemia, more amount of mortality. The protein, at least 2 grams per kg per day is required because 1 gram per kg per day is the protein. The baby will have a catabolism. 1 gram per kg per day will be an extra additional for the baby building. We need to increase 1 gram per kg per day to maximum 4 gram per kg per day. We need to start lipids 1 gram per kg per day. And you can increase by 1 gram per kg per day daily to maximum 3 gram per kg per day. So all this will be given in such a that calculating the calorie nitrogen ratio. The calorie nitrogen ratio should be around 150 to 200. Sodium, potassium, and magnesium will be added after day 3 after the baby at an adequate diet started losing weight and the baby's urine output is good. We'll start the calcium around 4 to 6 ml per kg per day of calcium gluconate will be started from the day 1 itself, and these babies have more amount of hypocalcemia. The multivitamins also will give from day 1. We'll monitor for the phosphorus in these babies of usually around 2 weeks. If you are able to give the considerable amount of fortification, we usually provide with the fortification. And if you are not able to feed the baby properly, then we can even give the IV phosphate therapy for the baby, maybe 1 or 2 doses. We'll monitor the sugars around 6 to 8 hourly, electrolytes daily or twice, alternate days. We measure the weight daily. Sometimes we measure the daily, twice daily also. We have a strict input and output monitoring. All the babies on TPN will monitor their lefties 1 or twice weekly. Whenever we suspicion of sepsis, we send a sepsis marker. Follow standard feeding regimen. Nowadays, as we are increasing all the NICU numbers, we are managing small babies. So the number of the doctors, the number of consultants, sisters, all there will be many. So we should have a consistent policy in the form of standardized feeding regimen in order to have an alterations in the feeding practices, which itself can decrease the chance of NICU. So standard feeding regimen is needed because the studies have found that there's 78% decrease in the chances of the necrotizing enterocolitis if you have a standard feeding regimen. Always start with the mother's own milk because it is tailor-made for the baby. Mother's own milk is not available. We can use the donor human milk as an alternative. But as soon as the mother is stable, we should motivate the mother to express her milk, continue the baby. We have, because we have a human milk bank, and we frankly we hardly uses any formula feed in our NICUs. That might be the chance for the decreased chance of the necrosis, enterocolitis, and feed intolerance. We start with around 10 to 15 ml per kg per day on day one, as soon as the baby is hemodynamically stable. And then we increase the volume by 15-20 ml per kg per day, and we give 2 hourly feeds by monitoring the feeds signs of the feed intolerance. So these are human milk bank where we get the milk from the different areas of the Hyderabad and needy tiny premature babies based upon the prescription from the doctor and after screening them from the infections, and we are giving at the free of cost. So for feeding management, initially we have initial TPN as the Elgan baby. The baby toilet feed for 7 days. Feed intolerance as 7 days as you see. This is an X-ray suggestive of dilated bowel loops. So baby was kept on NPO for 48 hours with a full TPN, start antibiotic and antifungal. The abdominal distension improved over the times, then aspirates have decreased. Subsequent X-rays were normal. We restarted the feeds after 48 hours and hiked as per the standard feeding regimen, and we were able to successfully achieve the full feeds by day 19. After that, we were able to taper the TPN. During the course, we tapered the TPN and stopped the TPN. So coming to the evidence, the standard feeding regimen is the best option because it increases the chance of NS by 75%. We need to start the trophic feeds. The colostrum coating is the one that actually need to be done for all the small babies because it decreases the chances of the infection and decreases chance of the ventilator associated pneumonia, and also the time to reach the full feeds because of the trophic feeds will be much higher. The trophic feeds, by giving the trophic feeds, it improve the motility of the intestine, decrease the chance of the atrophy of the intestine villi, and the hormonal and the digestive enzyme secretion will be regulated. We need to start the feeds as early as possible, preferably within day one, as soon as the baby is hemodynamically and respiratory stable, not because it decreases duration of the hospital stay. For less than 1 kg, we advance the feed with 15 to 20 ml per kg per day because it decreases, it leads to shorter time to reach the full feeds, decrease the risk of the invasive infections. Mother own milk, there's no need to emphasize that mother's own, because everyone knows that the mother own milk is the most important type of milk that we need to start because it has a dose dependent reduction in the NEC, BPD, and ROP. If breast milk is not insufficient, or the mother is not available, then the next option is donor milk because it definitely decreases the chance of necrosis and enterocolitis. We need to have a human milk derived fortifiers, but it is becoming a bit costly. So even the bovine-based human milk fortifiers are being used with better amount of weight gain and better amount of decreased chance of NEC. But if you have an option for the human milk-based fortifier, it's better to use always human milk-based fortifiers in these small babies because the chance of the necrosis and enterocolitis is low. And these small babies will always try to feed too early because the studies have shown that too early feeds in these small babies will have lead to earlier time to regain the birth weight and the shorter time to reach the full feeds. So the baby was continued on OG feeds till 32 weeks of the gestation and reaching 1.2 kg. We have a oromotor stimulation specialist in the hospital. Majority of the centers are having the oromotor stimulation specialist. We follow the POME, and we have initiated this POME at the 30 to 31 weeks of the gestation so that the early oral acceptance will be good. By around 30 to 33 weeks of the PMA, the baby started taking the spoon feeds and we have increased the volume, and currently 35 weeks of the gestation, baby is on full spoon feeds. Fortification is one of the most important things that we can do for the better weight length and head circumference of the weight gain. There are much studies having the early fortification, late fortification, but without any differences. So we usually follow the fortification around 100 ml per kg per day with a human milk fortifier. In these small babies, we try to provide with a human milk based fortifier till they gain some weight, adjust to the feeds. Then we transition from this human milk based fortifier to the bovine milk based fortifiers. And continue the babies on full fortified mother's own milk with the spoons, and we are doing the iron supplementation for the hemoglobin status. We routinely screen the babies for the jaundice, and this baby has received phototherapy as per the NICE guidelines. We have a strict ROP screening guidelines. We screen the babies around 2 to 3 weeks and subsequent follow based upon the stages of the baby by the ophthalmology team. Currently, the baby has a Zone 3 stage 1 ROP and will be following this baby. As these babies are the NSU graduates, they are the more exposure to these harmful medications like antibiotics, maybe because of the high sounds, because of infections. So we always try to screen these babies ABR. We usually do the ABR before the discharge, and this baby's ABR is normal, and we plan to do a by around 3 months of age. These babies, especially as the 34 weeks of the gestation babies, have less amount of the calcium and phosphorus transfer from the mother to the baby, so they're more chance for the osteopenia prematurity. And also, this initial milk, we are not giving the phosphorus, IV phosphorus routinely, and we're giving only calcium. And we may not fortify this baby until it is 100 ml per kg per day. The calcium and the phosphorus content of the mother's milk is also low. So we usually screen around 3 weeks with the calcium and phosphorus and alkaline phosphatase levels. This baby found with low phosphorus with elevated alkaline phosphatase. That's why we are giving the calcium and phosphorus supplements to the babies. And also we have advised the mother to take the calcium phosphate supplements rather than just the calcium carbonate supplements so that even her milk calcium and phosphorus content must be improved. We follow the high threshold cutoff of the top rail and we're still the baby is a 3 RBCs because the lifespan of the RBC in this baby is low and sometimes we need to have the more amount of the blood investigations even though we followed minimal quantity of the blood but still this baby had a sick and has infection. The chances of this and also the abdominal distension feed intolerance. So we may not able to give the adequate amount of the enteral nutrition. So this baby has 3 LRBC transfusion. And the next thing, that most important thing is provided the kangaroo mother care. So we are much pro for the kangaroo mother care. As soon as the baby is stabilized, we start the babies on the kangaroo mother care. Because the studies have been robust evidence that kangaroo mother care have significant reduction in the mortality by 40%, sepsis by 65%, and hypothermia by 72%. There is a better weight gain, better length gain, and better head circumference gain in these babies. And the studies have found that even at the follow-up, there is increased chance of the exclusive breastfeeding and any kind of breastfeeding and discharge. That's the reason why we follow the kangaroo mother care strictly in our practice. Currently, this mother is giving around 8 to 10 hours per day. And even the fathers have been encouraged in our unit to provide the kangaroo father care. The kangaroo father care studies have shown that by providing the kangaroo father care, the kind of the mental peace and the kind of the satisfaction the fathers are having is much higher than the father, and the levels of the stress levels have decreased significantly by giving the kangaroo father care, and also the baby is getting the equal amount of the benefit with the KIMS and the KFC. So both the mothers and fathers are trying to provide the care around 8 to 10 hours per day in our unit. So we usually discharge when the baby is on breastfeeding or even on the oral feeds and gaining around 15 to 20 gram per kg per day and reaching 1.5 kg. Maintain the body temperature by adequate wrapping without any additional heat source in the room temperature. And mother is confident enough in handling the baby, identifying the danger signs, managing the small problems that are happening because of the feeding, and how to maintain the temperature, how to care the baby, or how to prevent the infection. So when the mother is confident enough, we counsel the mother, we explain all the complications, we teach the basic resuscitation thing to the mother, we provide a bag and mask, and then we'll discharge the babies to the home. We have a strict follow-up clinic where we'll ask the babies to come to visit come to the follow-up once or twice in a week till 37 to 40 weeks and reach 2.5 to 3 kg. Thereafter, we increase the frequency 2 to 4 weeks till 3 months of post-conception phase, then subsequently 1 to 2 months during the first year of life. The babies are not growing well and there are any problems and we find the mother is not confident, we ask them to frequently visit us in order to assess the weight gain of the baby, the kind of the feeding and how the baby's overall condition is there. So we have a developmental screening protocol in place in our hospital. We not only the corrected age is used for the growth and the development assessment of all the preterm babies till 24 months of age. We screen at 3rd month, 6th month, 9 month, 12 months, and 18 months. The babies who are at the risk, we regularly follow up for early rapid development in the first 2 years at intervals of not more than 6 months apart. After the age of 2 to 3 years, if the child is progressing well, these assessments we usually shift to the annually at the school entry, then biannually till during the mid childhood age. So we use the DDSD 2 for the screening. This is a Deniver 2. This wheel for the screening. And we'll do the Hamilton angles for the motor evaluation till the 1 year of age. So these Hamilton angles where you see this adductor, heel to ear, popliteal, dorsal scarf sign, and based upon this months, we note the angles and based upon whether the angles are higher and the lower, we assess. So any abnormal screening, either motor or the delivered to, we refer to a developmental pediatrician for the Bailey assessment of infant or toddler developmental food. So in this way, we are managing extreme preterm babies. There are much more evidences are coming, and we can improve a lot by following the current evidences and even small things that we can do for the baby by maintaining the proper temperature, by providing the blended oxygen, by providing the delivery room CPAP, by providing the early rescue surfactant therapy with the LISA, with the Poractant alpha, early aggressive enteral nutrition, prevention of infection, Kangaroo mother care, early fortification, family-centered care, development supportive care. All these points will lead to the better outcome of the babies. And there's always a room for the much more things to be done in these aspects, which have a very strong impact on the baby development. So with this, I conclude my presentation. My take-home points are: we need to have implementation of evidence-based practice for the better outcome of these small babies. Golden hour management has a very strong positive impact on the baby survival and morbidity. Infection prevention is always better than cure, but early identification of infection and early action is also equally important. Standard feeding regimen with exclusive mother's own milk followed by the donor milk should always be implemented in order to prevent the necrotizing enterocolitis. One should have a structured screening and the follow protocols so that we don't miss any babies who is having the development delay or going the growth failure. The developmental support to care should be given for all the babies because it significantly improves the quality of the neonatal life. With this, I conclude my presentation. Thank you.